Dr. Hezron, I can't hear you.
Prof, we are starting in a minute.
All right.
Just allowing
Okay.
members to join.
Okay.
Yeah.
Okay.
Recording in progress.
Okay, esteemed members, good evening and welcome to today's webinar. If you can hear me, just send a message in the chat and let us know which PSK branch you're joining us from. Good evening, Dr. Patel, Dr. Duncan. Welcome. Thank you, Dr. Brian from North Rift. Good evening, Dr. Monica, Dr. Lewin from South Rift. Welcome. Thank you all for creating time to join this webinar. And just before we get started to the main session, I'd just like to know how many of you have registered for the conference that is coming up? If you've registered, you can just type yes on the chat. That's the poster. I see Dr. Mary Sang has registered. Thank you, Dr. Anyone else who's registered? Remember, this time the conference will be happening between 24th to 26th of June at Pride Inn, Paradise, Mombasa. And today is actually the deadline for the early bird. So for those who would like to enjoy the discount, ensure that you sign up by today at 11:59. So I see there's also Dr. Richard Macau who says yes, he's registered. Who else has registered for this conference? Just by typing yes, you can let us know. Good evening to you all. Those who've joined, welcome. All right, so I think that was just to create some awareness that today is the last day for the early bird rate. So ensure that you register in advance so that you enjoy that discount. So we're going to get started for today's session. And today's webinar is on optimizing OTC pain management in the community pharmacy. And our partner for this webinar is Helion, who's been our longtime partner for many activities. And we are glad that today we have this webinar, and it's going to be a first of many others that will be coming up this year. And for today, we are privileged to have Professor David G. Nyamu, who's going to be giving a talk on this topic. And then thereafter, I'll be having some presentations from the Helion team. And first, I'd like to just remind you, if you've not subscribed to the event on the PPB portal, ensure that you do so. Remember, we have a 7-day timeline for subscribing and claiming to the event. So just ensure that you just take a minute of your time, go to the PPB portal, search for OTC, and you should be able to find the event easily. And just a few ground rules. All participants are muted during the entire course of this session. And if you have any questions, kindly use the Q&A tab, which is at the bottom of the window, and your questions will be addressed by the presenters at the end of the session. Kindly note, this session is being recorded and will be made available on the PSK YouTube page. Just on the order of the session today, we'll be having some opening remarks from Enid Mora from Helion, Then we'll have a pre-test poll. And then we'll get into the presentation. Then we'll have a presentation from the Helion team. Then a Q&A. Then finally, we'll have a post-test. And then the announcements and closing remarks. So at this point, I'd just like to welcome Enid, who's the head of expert SSA at Helion, who's going to be giving some opening remarks, and then we can move to the next step. Enid?
All right. Thank you, Dr. Hezron, and good evening, ladies and gentlemen. It is such an honor and a pleasure to be amongst you this morning. A huge thank you to the PSK leadership for your continuous partnership over the many, many years that we've worked together. It's been such a delight to be part of the growth that you as an association have experienced, but we also as Helion, as we've grown to understand your needs and how we can partner even better. And it's just the beginning of the journey. We are hoping that 20, 30 years from now, we'll still be sitting and reminiscing of the many successes and the many things that we've done to impact society, to change the lives of our patients, and we'll do it together. For me, from Helion, I want to keep it really short. And it's just to reiterate the importance of your partnership with us and how we view it as Helion going forward. One of the things that we are very keen on doing is being value-adding partners who are keen to deliver reciprocity as we walk through this journey. What I mean by that is, yes, we are a commercial entity as Helion, but we understand that we can only move forward if we move forward together. And so my urge to you is that when you see Helion representatives come to your places of work and strike up conversation with you, we have very open and very willing ears to understand your needs and how we can partner. And you've seen over time in the way that we partner with you, even at the association, we're really intent on being different and engaging in a different way. So if you do have those bright ideas on how we can partner with you better, please share those with us. We are committed to making sure that we succeed together. And just once again, a huge thank you to PSK for always having a welcoming home for Helion. And like I said, we're going to be walking this journey for a very, very long time. Thank you, Professor Nyamu, for the partnership as well. Really looking forward to the session. And yeah, let's have a good evening. Thank you. Thank you. I'll hand it over back to Dr. Hezron.
All right. Thank you so much, Enid, and also for the continuous support that you've always given the pharmacists. So at this point, we're going to just do the short quiz. Meanwhile, as the presenter for today, Dr. Nyamu, is going to be sharing the slides. So just check on your screens right now. There should be a pop-up where we have a set of questions that you need to respond to. And meanwhile, I'll also read Professor Nyamu's intro as he sets up the screen. So Professor David G. Nyamu is a clinical pharmacist and associate professor of clinical pharmacy and therapeutics at the Department of Pharmacology, Clinical Pharmacy and Pharmacy Practice at the Faculty of Health Sciences, University of Nairobi. He teaches and supervises both undergraduate and postgraduate pharmacy students, and is also the academic leader of the clinical pharmacy program. In addition, for over 20 years, David has been practicing clinical pharmacy at Kenyatta National Hospital, which is the largest referral and university teaching hospital in East and Central Africa, and is currently the chairperson of Training and Assessment Technical Committee of the Pharmacy and Poisons Board, and a member of the Education and Continuous Professional Development of the Pharmaceutical Society of Kenya. His professional objective is to develop a career in teaching and research, specializing in clinical pharmacy, as well as provision of high-quality, professional, efficient, and effective pharmaceutical care services to the community. He has co-authored over 70 papers in a peer-reviewed journal and co-supervised over 70 master's student degrees and several PhD students to completion. graduated as the top student and received gold medal and along other academic awards at BPharm degree. So allow me to welcome Professor David G. Nyamu, who's going to be facilitating this session. Meanwhile, ensure that you give your responses for the quiz that we have on the screen. Then thereafter, we'll also have a post-test that will be carried out once the session is over. So I still see a few of you have participated. So just take a minute of your time and give a response to the questions that are provided. We have the first question. A 28-year-old woman presents with a mild bilateral headache with a pain score of 3/10 on the visual analog scale. She has no comorbidities and is not on any medication. What is the most appropriate recommendation? Is it diclofenac tablets, paracetamol, tramadol, or paracetamol and doxylamine? The second question, a 55-year-old patient presenting with chest pain radiating to the left should be managed with paracetamol or tramadol combination before referral. Is it true or false? Which of the following is not a part of the WARM technique of pain assessment in the community pharmacy? Who is the patient? What are the symptoms? What is the weight of the patient? Medications being taken. Then the fourth question, a 35-year-old man with a history of asthma presents with a musculoskeletal pain after exercise and he requests for diclofenac. What should the pharmacist do? Dispense diclofenac 100 mg once daily, recommend diclofenac gel, recommend paracetamol 1 gram, or add aspirin 600 mg. For those who are asking about the questions, it's just right on top of the screen. Or you can check on the window below, there should be a poll section. The sixth question, actually the fifth, a mother brings a 3-year-old child with fever and pain due to tonsillitis. The child weighs 15 kg. What is the correct dosing of paracetamol? Is it 120 mg every 4 to 6 hours, 150 to 225 mg every 4 to 6 hours, 240 to 300 mg TDS, or 60 to 75 mg TDS? So I see 21% have participated. If you've not, ensure that you do so before the presenter starts. Question 6, a 40-year-old patient presents with localized shoulder pain after lifting heavy objects with no comorbidities. What is the best option? Is it oral diclofenac, injectable NSAIDs, topical NSAIDs, or injectable corticosteroids? And finally, the last question, a patient with a history of peptic ulcer disease can safely use oral NSAIDs for pain if taken after food. Is it true or false? Questions are on the screen. Just check at the bottom of the screen. You should be able to see the poll option. Okay, so as soon as we reach 30%, I think we'll get started because of time. %29%. All right, so we'll now end the poll, but you're going to have a post poll so that we get to see the feedback that we have. Prof, maybe we could go through 1 or 2 questions that I think we also have we have almost the same answers. Nyamu, I'm not sure if you can hear me.
Dr. Hezlon, I can hear you clearly.
Okay.
So you want me to go through the questions now or later?
I think we can actually do it later, once we get the feedback. But meanwhile, we should be able to, we can actually start and then we can have the discussion.
Thank you. So allow me to share the slides.
Okay.
I don't know whether the slides are visible from your end.
Yes, they are visible. You can just have them on full screen.
Right now, they should be on a full screen.
Yes.
Thank you so much, Dr. Hezlon. Thank you so much for that kind introduction. Hey, some things I never knew that they exist. Thank you so much. And thank you so much, Helion, for this opportunity to interact with my colleagues, with my former students. So it's a great honor to be with you. Dr. Hezron confirmed that I'm audible. Please.
Yes, you're audible.
Yeah, today we shall discuss on how to optimize pain management at community pharmacy level. And really, this is not a new topic to most of us. It's something that you have seen, but maybe the way we have been doing it just so random. So we want to look at how we can streamline the way we practice in the community pharmacy. So I'll go straight head on. I expect that by the end of this discussion, you can actually be able to use simple pain assessment tools at community pharmacy. And we should also be able to appraise the WHO ladder, because again, we don't operate from the vacuum, we operate from the evidence. And there's WHO ladder, which I would expect all the pharmacy practitioners to be aware of. Then we'll look at how to match the pain types to therapy. And you can see some of those questions that you have answered there. Actually, they are relating to the type of pain plus the therapy that you can institute. Then we shall spend a little bit of time looking at paracetamol because it's a first line, and see why you need to recommend it as first line in most of the instances. Finally, we shall look at when to recommend a topical NSAIDs, and when should you refer your patients, especially when they are red flags, because not all pain can actually be managed at community pharmacy level. So part of the introduction
Prof, I think you're muted.
Sorry
Yes,
for that.
okay.
So pain is very common, especially in community pharmacies. And I think you can attest to that many patients who come to you actually complain of the pain. There are several studies which have shown that pain is quite common. Here you can even see the most recent study in 2026, somebody talking about how to assess the pain and how that pain is very common in the community pharmacy. So for you to effectively manage pain, you have to accurately assess that pain. You have to identify the appropriate analgesic and recommend that analgesic. You have to identify the red flags, and you have to educate your patients and do the follow-up. And there's a lot of evidence that pharmacists can actually ensure that safe, effective, and rational use of OTC analgesics at the community pharmacy level. So, why should you control the pain? There are many reasons why you need to control the pain. But the bottom line is that if you have good pain control, then there are better outcomes of the patient. Patients are comfortable, and there will be good care. And as pharmacists, we look at the aspect of adherence to the medication, because that is key for a pharmacist. Now, I'm telling you, there's no patient who can actually adhere to the treatment, even if it is a very good antibiotic, while they're on pain. So you have to control the pain. And apart from that, we're also concerned about the complications, because if you don't control the pain adequately, then you are likely to have complications, including deep vein thrombosis, because these patients are not likely to ambulate. So there are many reasons, but the main reason is we control the pain for better outcomes of the patient. So the pain assessment tools are many, but I'm going to discuss on two. And the assessment should be quick, should be structured, and patient-centered. Note the key words. It should be quick, structured, and patient-centered. Otherwise, if you stay there with the patient for 30 minutes or so, they're likely to go away. So what are these approaches? We have what to call the warm approaches. And these are mnemonics. And there are quite a number of studies talking about this approach, whereby W, the first W stands for who is the patient and what are the symptoms. For H is how long have been the symptoms. A is actions taken and medications currently used. So the warm approach is what I would recommend the pharmacists at the community pharmacy level to use. Who is the patient? Sometimes when patients come to you, they come to you as maybe being sent by other people. So you need to know who is the patient first. Because characterizing the patient is very important. Then what are the symptoms related to that pain? We shall look at clinical cases so that this aspect, this approach actually sinks in your mind. Then we also have the Socrates approach. And the Socrates is mnemonic for S for site, O for onset of the pain, C for character, is this sharp, dull, or throbbing pain, R for radiation, A for associated symptoms, T for timing, E for exacerbating risk factors, and finally S for severity. Again, to clarify on this, I'm going to give you a case of a patient so that we see how we use this approach to assess the pain at community pharmacy level. And then we can also use the pain severity scales. I think this is also quite common, whereby we use the numerical rating scale, whereby you ask the patient, using the scale of 0 to 10, how do you rate your pain? Some of you will tell you 5, they tell you 6, and where 0 is whereby there's no pain, and 10 is whereby there's that very intense pain. So we can also use the visual analog scale for those patients who are not able to read. You can actually give them this scale and tell them to point on that number line where they feel that their pain is, using these images. Okay, whereby 0, there's no pain, and 10 is the worst pain imaginable. And then you can classify the pain, where 1 to 3 is mild pain, 4 to 6 is moderate pain, and 7 to 10 is severe pain. Okay, so once you classify the pain, so what next is to manage? And there's a lot of evidence, and WHO came up with this ladder, whereby in step 1, there's mild pain, you just use non-opioids like paracetamol or NSAIDs. Sometimes you can combine with adjuvants like pregabalin, gabapentin, and the like. Step 2, whereby there's moderate pain, a scale of 4 to 6. We can use weak opioids like codeine or tramadol. We can also add non-opioid like paracetamol, or adjuvants. And severe pain, that is step 3, whereby you use strong opioids. I would expect that at community pharmacy level, we are likely to be dealing with the patients who are actually mostly in step 1, mild pain, and step 2, that is a moderate pain. For step 3, these patients are likely to be the ones who are admitted there and they're receiving those agents like morphine or fentanyl, plus adjuvants or non-opioids. So let's look at the case study on how to use the mnemonic worm. Here, your patient who is 40 years old, requesting for strong pain relief, and that's quite common. You have a patient who comes requesting for strong pain relief. So on home assessment is that who is the patient? This is an adult self who is 40 years old. And what are the symptoms? The patient describes the pain as dull, aching, and it's on the lower back, and is worse on bending or sitting. How long has been the pain? Perhaps 3 days, suggesting it is an acute pain. And action taken, she has tried paracetamol, which is not effective. And the medications taken, no current medications, no comorbidities, no allergies. So on assessment, you find that this is acute musculoskeletal pain on the lower back, and there are no red flags to warrant referral. So how do you manage? You can give ibuprofen or diclofenac, 400 milligrams of every 8 hours after food, and the patient can continue paracetamol if needed. And then also recommend on pharmacological therapy, whereby you can recommend rest, warm compresses, and avoiding heavy lifting. And you advise the patient to return if the pain worsens or persists more than 5 days. Okay? Then on Socrates, we have a 54-year-old man who has chest discomfort. He walks into a community pharmacy with chest pain. 54-year-old man who has chest discomfort and is coming to a pharmacy, and it's quite common. So Socrates cites the site of the pain is central chest. The onset, it described as started suddenly 1 hour ago. The character is heavy pain, squeezing kind of pain, radiation is spreading to the left arm. The symptoms associated, sweating, nausea, sometimes vomiting. And the timing, it's continuous pain, which is not relieved by rest. Exacerbating factors, no relief with rest. Severity, you call it as 8 out of 10. So on assessment, to find this is not a patient that you can actually manage at community pharmacy level, because this is a suspected cardiac ischemia, and most likely is a cardiac chest pain, and it's possibly an emergency. So what do? So refer the patient to the hospital and advise urgent medical attention. They do not delay the process, because there's likely to be angina. Actually, an angina can be having of myocardial infarction. So refer the patient, okay? Now let's look at how you can match pain types to therapy. Here you have a patient who comes with a headache. So on headache, you have to consider the types. Is it tension type headache, whereby the patient presents with a mild, moderate bilateral headache? Or is it migraine, which is usually unilateral throbbing with or without nausea? So once you get the type of headache, and tension type headache is the most common type of headache at community pharmacy level. You can also get migraine, but tension type headache is the most common. So management is, the first line is paracetamol. And alternative, you can actually give NSAIDs. For migraine, you can also add antiemetics because they come with the nausea and vomiting. That is headache. First line paracetamol. This one, I think I've talked about this for the headache. Then musculoskeletal pain. Somebody comes perhaps with maybe lower back pain or shoulder pain. You have to consider the type of that pain. You have to know the type. Is it a sprain? Is it a strain? Or is it just back pain or joint pain? Management, the first line you have to think about is paracetamol. If it is moderate pain, you can consider giving NSAIDs, either oral or topical, depending on the number of joints involved, depending on the severity of that pain. And adjunct, you can actually use the RICE method, whereby you advise the patient to rest, or use some ice packs, or compression, or elevate the affected area. So that is musculoskeletal pain. If the patient comes with inflammatory pain, there's inflammation, whereby you find there's pain, there's swelling, there's redness, there's warmth on the site, especially those patients who come with something like cellulitis. So consider the type of causes of that inflammatory pain. Is it arthritis? Is it tendonitis? Is it cellulitis? And management, because this is inflammatory pain, consider giving something which is anti-inflammatory. So NSAIDs are more effective. And as you look at the NSAIDs, you have to consider the risks before recommending the oral NSAIDs, which include the GI risks or even risks particularly pertaining to the renal disease or even heart disease. And the studies have shown that COX-2 selective NSAIDs are safer. They are not absolutely safe, but they are safer than the COX-1 inhibitors. I hope at pharmacy level, at the pharmacist level, at community pharmacy, you understand what I mean by COX-2 and COX-1. Diclofenac is a COX-1 inhibitor, celecoxib is COX-2. And because this is inflammatory pain, which can be due to an infection, you need to rule out the infective process. Because if it is cellulitis, you have to treat that infection. Today, we are talking about the pain management. So we are now going to look at paracetamol, which is usually the first line in most of the instances. And I wish to remind us about the mechanism of action of paracetamol. I know some of you may have forgotten that paracetamol is one of the safest molecules that we have when it comes to pain management, because the way it acts centrally. And in the brain, it inhibits the COX enzymes in the CNS. And once it inhibits the COX enzymes, we will find that there's decreased protein synthesis, prostaglandin synthesis, particularly prostaglandin E2. And we know the effect of prostaglandin E2 is when the levels are low, the pain is also low, and the fever also decreases. So again, on the spinal cord, paracetamol activates serotonergic pathways, whereby it enhances pain inhibition. And also the CNS, paracetamol is metabolized to a compound called AM404, which acts for some receptors. And these receptors are the ones which elevate the levels of endocannabinoid. And these endocannabinoids actually act as pain relievers. Now, having known that paracetamol works in the central nervous system, let us look at why is it then the first line? There's a lot of evidence, scientific evidence, a lot of research has taken place to recommend paracetamol as a first-line agent. And this is why even WHO is recommending paracetamol as a first line, because for WHO to recommend paracetamol, a lot of research must have been done. So it is effective and good. It has a good safety profile in majority of the patients, including majority of the patients who have comorbidities. It is suitable for all age groups with dose adjustments, including children. You can't give NSAIDs to children. They are not very suitable. It is suitable for a wide population. Again, I said it can be used by a majority of the patients who cannot take the NSAIDs. Those patients are the ones, maybe they are likely to have peptic ulcer disease, they're likely to have asthma, and they are likely to have maybe heart diseases. You can actually recommend paracetamol. And generally, it's safe in pregnancy. And from the mode of action, you have seen it is acting centrally. Remember that most of the adverse effects of analgesics are actually due to inhibition of the COX enzyme peripherally. So because it acts centrally, it does not inhibit platelet aggregation. And finally, it does not predispose to hypertension, to heart diseases, to renal diseases like NSAIDs and other analgesics. Okay? So those usually we give 500 milligrams to 1 gram every 4 to 6 hours, up to a maximum of 4 grams per day. And in children, we recommend a dose of 10 to 15 milligrams per kg every 4 to 6 hours. Some authorities recommend even up to 75 milligrams per kg per day. But for practical purposes, for the community pharmacy levels, I would advise 10 to 15 milligrams per kilogram every 6 hours, 4 to 6 hours. And what I mean by that is that if you take a child who is 10 kg, we are saying that you need to give 10 times 10, that's 100 milligrams to 150 milligrams every 4 to 6 hours. And it is very, very important to compute that dose in children, because children are not small adults. And there are quite a number of studies which has also been done that there have been problems in dosing of paracetamol among the children. Some of the key counseling points is patients should avoid overdose. What happens is that when you give these patients paracetamol and you tell them to take every 4 to 6 hours, they take the first 1 gram. After 2 hours, they find that the pain is not decreasing. They take another dose. So you need to advise them to avoid the overdose because of hepatotoxicity. As you give this agent, you need to check whether the patient is taking other products which contain paracetamol. We know right now there are so many products out there with fixed dose combination of several analgesics. You find that even one product could have even up to 3 analgesics: paracetamol, diclofenac, maybe aspirin, and you know them. Okay, so let's look at another case study. Here is a 22-year-old college student who comes with a mild, moderate to moderate headache for 2 days. And when you do the assessment using the worm, you find that there is no prior medication, there are no comorbidities or allergies, there are no red flags, like there is no fever, there is no trauma, there are no neurological symptoms. So when you assess, you find it's tension type headache, and this is suitable for over-the-counter management. So what do? Give paracetamol, 1 gram every 4 to 6 hours, up to a maximum of 4 grams per day. And then do the counseling. Tell the patient not to exceed that dose, and to avoid duplicate products which are paracetamol, and to return if the pain persists for more than 3 days, or if the pain worsens. So you can see how we select we are not giving the diclofenac or ibuprofen. We are looking at first line as paracetamol because it has been shown to work in a number of patients. Again, this is now a common case whereby this patient comes to the pharmacy, and it's quite common because remember that you as a pharmacist, you are the first contact. A community pharmacy is the first contact with the patient. This is a 65-year-old man who has multiple comorbidities. This patient has hypertension, he has type 2 diabetes mellitus, he has peptic ulcer disease, and there's a query about the chronic CKD, chronic kidney disease. So it comes to you with moderate knee pain for 3 days, and it is worse with movement. And it's quite common. Hypertension, diabetes, peptic ulcer disease. And you have to select an analgesic for that knee pain. So which analgesic? So when you do the assessment, you find that the current medication the patient is on amlodipine, 10 milligrams once a day, and hydrochlorothiazide, it's quite more common. Amlodipine for blood pressure, hydrochlorothiazide also for blood pressure, then metformin for type 2 diabetes, and is also on triple therapy for peptic ulcer disease. It's not amoxicillin, clarithromycin, and metronidazole for peptic ulcer disease. So this patient has those multiple comorbidities and multiple drugs. You're even worried about the drug interactions or drug disease interactions. So when you assess on that knee pain, there are no trauma or red flags. There is no prior analgesic taken by this patient. So this pain, the moderate knee pain for 3 days, is likely to be from osteoarthritis. So what do you do for that patient? If it was a class, if it was a physical discussion, I would ask each one of you to state what you need, what you can do. But let's see what you can do. Now, what is the concern for this patient? The concern with using NSAIDs like ibuprofen, diclofenac. When you use them, there is increased risk of GI bleeding. Remember, this patient is having peptic ulcer disease. Because of the possibility of CKD, if you use NSAIDs, there is risk of renal impairment. Remember the way the NSAIDs cause renal impairment through inhibition of the prostaglandin synthesis, particularly prostaglandin E2. What you're going to do is that if that happens, then there is diminished perfusion of the renal, of the kidneys. And when you use the NSAIDs, it may worsen hypertension. We do the same mechanism, inhibition of the prostaglandin synthesis. So what do? You are left with a very little option, and whereby now you take the first line agent, that is paracetamol, which is the safest. And you give 1 gram probably every 4 to 6 hours, up to a maximum of 4 grams per day. Why are you choosing paracetamol? It has been shown to be effective for mild to moderate pain. This patient is having mild, moderate pain. There is minimal GI irritation when you use paracetamol. It is safe in renal disease. It is safe in hypertension at correct doses. So that is why we choose paracetamol. And the key point is that if you get a patient who has complex comorbidities, then paracetamol is the safest first-line agent at community pharmacy level. I want to emphasize that if you receive a patient who have complex comorbid conditions, then the safest product is paracetamol. Don't go to diclofenac, don't go to other agents, okay? Now, we look at the topical NSAIDs. Can you use the topical NSAIDs? Remember, topical NSAIDs are quite many. You have the creams, you have the gels, you have the sprays containing various ingredients. Some of them have diclofenac, others have ibuprofen. And they are specialized agents, which they differ with the formulation type, and they also differ with ingredients. They also differ with onset and duration of action. But sometimes we find that perhaps sprays or gels work faster than the creams. So when should you prescribe the topical NSAIDs? Number one is when there is localized pain, like localized musculoskeletal pain, localized joint pain. There is not multiple joints. When the patient presents with sprains and strains, you can use topical NSAIDs. When the patient presents with osteoarthritis, and particularly maybe one joint is the one which is involved, you can use topical NSAIDs. And you can also use when there is soft tissue injuries or when there is inflammation, particularly when it is localized. So you can use the topical NSAIDs. The advantages is that they have lower systemic absorption. That means reduced GI effects, reduced renal effects, reduced cardiovascular effects, side effects, effective for local pain relief, and they are better tolerated, and they have a better safety profile compared to the oral or systemic NSAIDs, and they have rapid onset of action. You can actually use them for long-term use, unlike the oral NSAIDs. They are convenient and easy to use. You don't have to tell somebody to carry water to take them. They can actually apply the topical NSAIDs wherever they are. Even if they're in the office, you can actually use them. And when you use the topical NSAIDs, it minimizes the risk of drug-drug interactions. Okay. So what are the red flags that this patient require to be referred to a particular physician or a particular consultant? Number one, when the patient presents with the chest pain, particularly the central chest, it could be a sign of cardiac ischemia. There's a problem maybe in the coronary artery. So these patients are the patients who are likely to be having angina. So once you characterize that pain, and you find most likely it's cardiac ischemia, angina, or these patients are having maybe chronic ischemic heart disease, please refer them. Those with the fever, and particularly because of systemic infection, and you don't know what is a systemic infection, that is a red flag. If the patient presents with pain, and this pain happens to be a sustained pain for some time, maybe after a fall, or there's history of trauma, you suspect the fracture, and you can't treat the fracture at the community pharmacy level. You need to refer them. 4, if the patient comes with the pain and some neurological symptoms, like they come with the pain accompanied with numbness or weakness, maybe somebody is having hemiplegia or paraplegia, then you have to refer those patients. Could it be a central nervous system issue? Number 5, pain which is lasting more than 1 to 2 weeks without improvement can mean anything, including even cancer. So please, those are not the patients that you can treat over the counter. If there's severe pain which cannot be explained, Somebody comes and is having severe pain, you're trying to use the Socrates or the worm, and they can't even explain the type of that pain. You need to refer for further evaluation or further assessment. And if the patient comes with pain and they are losing weight, and they are losing weight not because they are going for the gym or for the exercises, it's because they are losing weight because there's something happening in the system, whereby we call it unintentional weight loss. This is likely to be cancer. It's likely to be malignancy. Just please refer these patients, okay? What are some of the counseling and patient education that you need to do? Advise your patient to use the lowest effective dose for the shortest time. If paracetamol 500 milligrams every 4 to 6 hours can work, that's the lowest dose. Use it for the shortest time, maybe 3 to 5 days, not chronically. Number two, to avoid combining multiple NSAIDs. There is no added value. If one NSAID can work, then why do you have to combine? Unless somebody is having severe pain. But I don't think at the community pharmacy level, you are likely to manage that severe pain. To adhere to the dosing intervals. If it is 4 to 6 hours, please, it is 4 to 6 hours. If every 6 to 8 hours, every 6 to 8 hours. If it is 12 hours, every 12 hours. If it's once a day, once a day. And if the pain persists, to seek medical care. They should not be coming to your pharmacy and you are recommending one analgesic after the other. If this severe pain persisting for some time, kindly, they need to seek medical advice. So what is your role as a community pharmacist when it comes to pain management? One, you need to track the patients effectively. You need to understand what is the pain, kind of pain. You need to evaluate that pain. That means you correctly assess the pain using those tools that I've discussed. Recommend the most appropriate over-the-counter therapy, depending on the type of the pain. Then you need also to prevent medication misuse. Patient may come asking for tramadol, asking for paracetamol, asking for many things. So you need to advise them and prevent the misuse. Number 5, identify and refer serious conditions. If you find somebody is having chest pain, probably due to cardiac ischemia, please refer. Chest pain does not mean that this patient is having pneumonia. It's not having it's having TB. You need to refer. And then finally, provide ongoing patient education when it comes to these analgesics. In summary, in order to optimize the over-the-counter pain management, then you need to have structured pain assessment. We have discussed the two tools, the worm and the Socrates. Choose one and then structure and assess that pain. You need to match the pain type to the therapy. If it is headache, paracetamol. Musculoskeletal pain, paracetamol, or you can give the NSAIDs. And always remember, paracetamol is the first line. For those patients who have multiple comorbidities, they have multiple drugs, then paracetamol is always the first line. And you need to know when you can appropriately use the topical NSAIDs. They are there, they're in the pharmacies, quite a number. When can you use them? I know most of us are likely to forget using those topical NSAIDs. When patients come to you, you're likely to give them the oral NSAIDs, and you're likely to forget that you also have the topical, which can act when there's localized pain. Then you need to recognize the red flags. At what point should you refer the patient? And finally is the referral mechanisms. I always advise that if you're working in a community pharmacy, that phone of yours or that book that you have should have all the contacts for all the types of physicians or all the types of consultants in various fields, so that the referral mechanism becomes easier for you. If you want maybe a cardiologist, if you want maybe a gynecologist, you need to have the contact. We need to have referral mechanism for these patients, okay? Those are some of the references that you used, and I wish to say thank you very much for giving me this opportunity to discuss the over-the-counter pain management at community pharmacy level. Thank you to you. Thank you so much. Over to you, Doctor. Over to you, the lead. the moderator. Dr. Hezron?
All right. Thank you. Thank you so much, Prof. Nyamu, for that presentation, and also for just reminding us on some of the things that we learned back in school. So I think at this point, I'll just encourage everyone, if you have any question, kindly put it at the Q&A tab. Professor Nyamu will be around to respond to those questions. For those asking about the slides, we'll organize when the CPDs for this event are being sent, they'll be linked to that email. So for any questions, ensure that you type them on the Q&A tab. And meanwhile, maybe Prof, you can just be looking at some of the things that are coming up on the Q&A tab, but as of now, we'll be moving on to the next presentation that will be done by the Helion team. Caleb and Vivian.
Hello, Dr. Nyamu. Sorry, hello, Professor Nyamu. Hello, Dr. Hezron, and all the attendees. So just
Hello.
Yeah, welcome. So I think we'll start with the quiz first, and then you can do the presentation. So allow me to just launch the quiz as you set up the slides. So for all the participants, just check on your screen. You should be able to see a poll that has just popped up. So just take a minute of your time and respond to those questions. Then the Helion presentation will be started by Vivian.
Yes, so thank you once again for this opportunity. My name is Vivian Omondi, an expert engagement partner from Helion. So the poll is actually on the screen. It would be best if each one of us could be able to attempt the questions. Then as we go through with our presentation, we'll be able to know what we did not get right and where we need to get it right. So the first question is Panadol Advanced with Optisop technology is a unique formulation that contains, you can actually be able to choose any of the above that seems suitable according to your knowledge. Then I'll also request Dr. Hezron on your end, if you'll be able to see the polls so that at least when we get to about 35%, then we can proceed on with the presentation. Thank you.
Okay. So at the moment we have 11%, so we still need some responses to come in. I hope everyone can access the poll. If you're not, just check at the bottom of your screen. If you're using your phone, click on More, and then there's a section where you can select the poll or quizzes. So just click on More on one of the buttons that is at the bottom of the tab, and you should be able to see poll or quizzes. We're at 16%. Just take a minute of your time, go to the poll and give your response. We're at 20% now. We still need more people. Dr. Rashid and Dr. Ruth, just go to the bottom of your screen. There's an icon that is written More. Once you click on it, you should be able to see poll or quizzes. It's just close to where the settings is. We're almost there. Just keep trying, give your responses. For those who are unable to access, just check at the bottom of your Zoom tab where the participants chat, react, share. There are a couple of icons at the bottom, and one is written more. So if you click on more, you should be able to see around 5 items: show CC, show the captions, poll or quizzes, hide reactions, or settings. So once you click on poll or quizzes, you should be able to give your response. Okay, we are 30% now. Should we still go on or wait till
I think we can proceed as the
Okay.
others attempt them. So I'll also request, in case you have any question, please put it on the chat in the chat box. We will go through them once we are done. So kindly confirm if you are able to see my presentation from your end.
Yes, you can see.
Thank you. So today we'll be talking about managing pain using Panadol. And the reason why we are going to talk about Panadol, a lot has been mentioned by Professor Nyamu. And one of the things that really caught my attention was the case for study, where he was looking at the clinical concerns with NSAIDs. And he really emphasized on the possibilities of gastric bleeding in some cases. And NSAIDs can also actually cause renal impairment. We wouldn't wish to give a lot of treatment burden to the patients who already have such conditions. And then the third one, it was that it may actually worsen hypertension in those patients who are already hypertensive. So we are actually leading the way with a very strong brand portfolio. As you can see, as highlighted on this slide, we have the Panadol Advance, Panadol Extra Soluble, and Panadol Extra, then Panadol Cold and Flu. And of course, the kids are also not left behind. We have the Panadol Children. So I know quite a number are asking a lot of questions like, why do we have Panadol Extra and Panadol Extra Soluble? The difference is Panadol Extra is with Optisol technology, and it is actually taken with water. But the Panadol Extra Soluble is just the effervescent formulation of the Panadol Extra. The word extra, it's because it has caffeine added to the paracetamol. So that is what makes the Panadol to be called Panadol Extra. So as we proceed on, we just want to highlight why Panadol is more than just a paracetamol. When you look at these three things, most of the times when a patient walks into a pharmacy and they are in a lot of pain, they will actually be looking at something that is going to give them quick relief. So when you look at Panadol, you will actually be able to get fast-acting pain relief that is actually clinical proven. And it is available in more than 120 countries around the world. Then this year, the good thing about Panadol, which is Panadol Advance, we're actually celebrating 70 years of existence because we've been able to help generations and generations to find relief from their pain. So I will major on the Panadol Optisol technology. And this is what makes our Panadol to be differentiated from the other standard paracetamol in the market. So Optisop technology involves or contains three components. One of them is alginic acid. So what alginic acid does, it is hydrophilic, and what it does, when a patient takes it in the stomach, it draws the water around the stomach and then it swells. So that is what makes it to disintegrate 5 times faster. Apart from that, we also have calcium carbonate, which also helps with the faster disintegration. Then crospovidone, which is a super disintegrant. So when you look at these three components, this is what makes Panadol Advance to disintegrate 5 times faster as compared to the standard paracetamol in the market. I will quickly show you a diagram which will elaborate why Optisop technology is important when you're looking at giving quick relief to a patient who presents with pain. So in this first diagram, it actually shows that when a patient takes the Panadol Advance, and due to the Optisop technology, the drug will be able to disintegrate very fast. And as it disintegrates, it does not stay still in the stomach. It actually moves into the small intestine. And this is what now will make the paracetamol to go to the site of action. Then it starts to cause the therapeutic effect. So this kind of a patient, in 20 minutes, they will actually be able to get full therapeutic relief. So this means that when a patient takes Panadol Advance with Optisop technology, it will actually take 25 times faster to reach the Tmax, and it will also take 37 times faster to reach the therapeutic threshold. And this is what makes it stands out as compared to the standard paracetamol in the market. When you look at the lower diagram, you find that this patient who takes the standard paracetamol, they've already taken the drug and it has disintegrated, but it is still intact within the stomach. So what this means is that this patient will not be able to get the relief that he or she needs. So I will quickly run some few demonstrations just to differentiate the technology that we are looking at today in depth. So here in the first demonstration, we are going to look at standard paracetamol. Then the second diagram will be of, the first two diagrams are going to contain different standard paracetamol in the market, but then the third diagram is going to contain Panadol Advance. These are taken in with water. So the dissolution test, the dissolution solution here, we took we actually mimicked the stomach environment. So we used the vinegar, and you see when you look at the stomach environment, the pH is always between 1.5 to 3.5, and vinegar is 2.5. So I will quickly run to the test so that we are able to see what this means. Yes, so as you can be able to see, Panadol Advance has completely disintegrated in less than 2 minutes. And so that is what makes it 5 times faster in terms of disintegration. So therefore, it means that when you have a patient taking Panadol Advance and the standard paracetamol in the market, your patient is going to get quick therapeutic effect. Then the second one is going to be a comparison when you have a patient taking Panadol Advance and Panadol effervescent formulation. So it's also going to take less than 2 minutes. I know there's that psychological assumption that if a patient has the Panadol effervescent formulation, they will get quicker relief as opposed to that patient who is taking Panadol Advance. When you look at this video, you find that Panadol Advance is still actually disintegrating much faster as compared to the standard paracetamol and of course the effervescent formulation. It's already about 45 seconds, but the Panadol Advance has completely disintegrated, while the effervescent formulation had not yet disintegrated. So this clearly tells you that when you have a patient who is taking Panadol effervescent formulation and one is taking the Panadol Advance, still the patient taking the Panadol Advance is going to get faster relief as opposed to the patient taking effervescent formulation, because for them, they have to wait until the drug is completely dissolved in the glass of water. That's when they can be able to take it in. While the other patient taking Panadol Advance, you remember the OptiSop technology we highlighted, as the drug disintegrates, the patient will actually be getting therapeutic effect as time goes by. And so here we are also going to compare two patients, one taking the effervescent formulation of the Panadol extra soluble and the other one taking the standard effervescent formulation within the market. So remember, Panadol extra here is actually having caffeine, while the standard paracetamol, which is effervescent, is having plain paracetamol. Yeah, so both of them were actually dissolved in a glass of water, because we have to, the requirement is any effervescent tablet has to be dissolved in a glass of water. So here we decided to dissolve the two tablets because now we are looking at a more stronger pain relief medication. Remember the caffeine. Caffeine acts as analgesic adjuvant. It basically potentiates the action of paracetamol. So if you have a patient who presents with a stronger pain and you're still a bit hesitant in giving the Panadol extra soluble, the plain paracetamol, and you're also a bit hesitant in initiating these patients on NSAIDs, then Panadol extra soluble would actually be best, because it is 37 times much stronger when it comes to pain relief. So other brands or portfolio of Panadol, we have Panadol cold and flu. And then when you look at the prices, we try to make them a bit much more affordable to literally both the community and even those who come to the hospital. I know sometimes a patient might come when the cover is almost depleted, and so you're actually looking at a drug that will not deplete the cover completely, but the patient will be able to go with something killer at home. So as you can see, Panadol Advance, a pair is just 15 shillings, meaning a daily dosing for an adult dose is going to be 45 shillings. And then when you look at Panadol Extra, it is only 20 shillings per dose. So daily dosing here again is 60. And then when you look at Panadol Extra Soluble, you find that a pair goes for 50 shillings. So again here, when you're looking at, I know there are also those patients who come to you and they feel like if they get a painkiller, which is of a higher value, then psychologically they feel like they've really gotten the best from you. So if you're also looking at a stronger painkiller, remember we've talked about 37 times much stronger as compared to the standard paracetamol, then you can actually recommend Panadol extra soluble. And then another thing I wanted to highlight, Panadol is one of the safest medication, just as Professor Nyamu had highlighted. You can actually give it to quite a variety of patients. Those patients who present with GI irritation, those patients who are asthmatic, those patients who present with cardiovascular comorbidities. You remember he talked about NSAIDs precipitating or worsening the hypertensive condition of some patients. Then, of course, when you also look at a drug that can actually be consumed either on an empty stomach or with meals, then with Panadol, you are good to go. And so it is widely available, and majority of the patients when they come to you, pain presents as the first symptom. So they're looking at you advising them, giving them the right medication that is safe. And we also talked about irrational use of NSAIDs. So when we look at all this, we find that we're actually having a legacy that is safe, that is rational in terms of analgesic use, and readily available. With this, we're actually celebrating 70 years of expertise, and we know that you are the first point of contact to our patients. It would be great if today we leave this meeting knowing that Panadol Advance is not just a paracetamol, but it is actually a drug that is much, much safer and most effective in quite an array of patients. So thank you very much for your time. And we'll be looking through the chat box so that in case there's any question, we can be able to handle. Thank you so much. Back to you, Dr. Hezron.
All right. Thank you so much, Vivian, for that presentation. I think that was a very educative presentation. And I see some good comments from the crowd as well. And I see you also have a classmate here. I think Dr. Stephen Kimani. Yeah. All right. So we'll just get into the questions now because of time. And I see we have a couple of questions that have come up. And the first one, I think it goes to Professor Nyamu. So one of the participants is asking, why is paracetamol not classified as an NSAID since it also inhibits COX, or is it because it works centrally?
Dr. Hezron, do I respond to that, or I wait for a couple of questions then I respond? Maybe.
Okay. How do you like to go about it? Okay.
A couple of questions and then I respond.
Okay.
Maybe three at a go.
Okay. All right. So there's that, and the other is it says Prof has demonstrated the tools and expertise to improve health outcomes in pain management. And is this service offered for free in the community pharmacies? If so, what is the incentive? And if there is a fee, how much? And what would be the legal and practice implications? And then I think the last one would be on any clinical relevance of COX-3. Maybe we can start with those ones now.
Thank you so much, Dr. Hezron. And thank you, colleagues. I can see a lot of comments on good presentation. Thank you so much for those wonderful comments. To respond to these wonderful questions, why paracetamol is not classified as an NSAID is the way it acts. Remember, I said that paracetamol inhibits the COX, but it does it centrally and it has other mechanisms of action. So why it is not classified as an NSAID? Because it acts centrally. It does not inhibit the peripheral COX enzymes. Then on the on the assessment tools, this is tricky because yes, are presenting the assessment tools, but it depends on how you want to use it. There is no rule, there is no law dictating that the pharmacists cannot charge for the services rendered. I know there are some clinicians, clinical pharmacists who are charging for the services. So I can't respond on that on how much you can charge for the assessment, but it depends on how you want to do it. If you want to charge, well and good. How much? I don't know. It depends on your level. But there is no rule, there is no law that says that pharmacists cannot charge for the services rendered. Maybe when it comes to issues to do with the insurance, or like SHA or SHIF, then maybe it is a time that the pharmacist can recommend that maybe we need to consider that when it comes to allocation of the SHA or SHIF services, so that the pharmacists are reimbursed when they do the medication therapy management or they do the clinical assessment of the pain at community pharmacy level. So for how much, I don't know. The other question was on what? Remind me, Dr. Ezra.
The clinical relevance of COX-3, if there's any.
COX-3, up to now, there's minimal clinical relevance, I think, and it is not widely studied. So it's not something that we can embark on because the ones which are highly studied is the COX-1 and the COX-2 enzymes. Thank you so much, Ezra.
All right, thank you,
Other
Prof.
questions?
Yes. So there's another one for the patient with hypertension, type 1 DM. Can we give paracetamol and tramadol? And then the other is, what's your opinion about frequent systemic use of diclofenac, despite the alert about it having more severe toxicities? And I think the third one is, other than paracetamol and diclofenac that have antipyrectic activity, what other options do we have in a patient with drug-induced liver injury?
Thank you very much for those questions. I'll respond to the first question, the patient with hypertension. Can we give tramadol? Can we give tramadol with the paracetamol? The answer is it depends on the severity of the pain. We know tramadol is an opioid, but which is used for mild to moderate pain. So depending on the severity, we can use it is relatively safe. But remember that tramadol is a prescription drug. And we wanted to see at the over-the-counter what kind of analgesic, what options are available. So if you have to give the paracetamol and tramadol, yes, you can give, but depending on the severity. And remember, tramadol is a prescription drug. Then on the use of diclofenac, this is a very, very interesting question because people are using diclofenac like biscuits or sweets. You find somebody is having mild pain, give me 2 diclomo tablets, which is, I think, is 5 shillings or 10 bob. Please advise your patient that chronic use of diclofenac can actually precipitate hypertension, can actually precipitate heart diseases, can actually predispose to renal diseases. Kindly advise them. Then options available for paracetamol in those patients who have liver injury. Those patients who have liver injury, depending on the extent of the liver injury, Well, you can use the options would be maybe the opioids, and here we are talking about the tramadol and the like. And again, it depends on the severity of the pain. And remember that paracetamol can also be used in liver disease, depending on the severity. What you need to do is you actually titrate the doses, and you give the lowest effective dose possible. And there's a way you can compute the dose depending on the extent or the level of the severity of the liver injury. Thank you so much. Dr. Hezron, can we go to the next bundle of questions?
Yes. So we have the next question from Dr. Mark, who says, we have a lot of combination tabs in the market with paracetamol plus NSAID or paracetamol plus muscle relaxant, etc. If you're able to comment on that. Then there's someone who's asking, is it okay to give Zulu MR and the likes to a patient with back pain resulting from lifting heavy weights? And the third one is a 65-year-old woman with hypertension and CKD is experiencing thinning in smaller of one of her legs and pain. What could be the cause and treatment plan?
Thank you so much for those questions. The use of combination products, we are aware there are very many. There are very, very many. I don't want to mention them because you know them, whereby you find a product is containing paracetamol, it's containing diclofenac, it's containing muscle relaxant. Remember that when we were discussing the over-the-counter, we said that avoid use of those combination. If use one product, if one product can work, and we see the first line agent is paracetamol, and we know that companies are out to make some money. Of course, I've not seen any evidence on those combination products, any scientific evidence backing the combination of those products, of those ingredients in those products. So whereby one product, one agent can work, there is no need of combination products. That would be my recommendation. The other question was on the use of Zulu MR. We know Zulu contains aceclofenac, paracetamol, and a muscle relaxant. And somebody is asking whether they can use it for back pain. Again, depending on the severity of pain. If the pain is localized, why don't you use the topical NSAIDs, which have less cardiovascular or GI effects? So depending on the severity of the pain, of that back pain, then recommend the most appropriate agents. And depending on the extent of that back pain, if the whole back is having the problem, then you can go to oral products. First line agent, paracetamol. If the pain is severe, or if the pain is accompanied with maybe inflammation, and there are no comorbidities, then you can think of the NSAIDs. You can think of the NSAIDs, and particularly think about the COX-2 selective NSAIDs. They are not absolutely safe, but they are safer than the COX-1. On the use of the 65-year-old with the CKD, and there is unilateral leg edema. We may not know the cause of that unilateral leg edema. Perhaps we may need to do some Doppler scanning to find the cause of that edema, but you can now just speculate the possible causes. Could it be maybe it is a Patorino syndrome, the liver is having the problem, or could it be it is the effect of the kidney disease, but it needs to be evaluated. It can even be maybe DVT, so it needs to be evaluated. We can't know the cause until we do the assessment. And those are the kind of the patient I was saying that you need to refer, because that is a red flag. Thank you so much, Dr. Hezron. Can we go to the next? I hope I've satisfied the people who are asking the questions. Can we go to the next bundle of questions?
Okay. So the next question is on whether caffeine content in Panadol Extra poses a risk to hypertensive patients. That's the first one. The other is if you could comment on alcoholics with arthritis and the long-term use of paracetamol. The third one is, I think this is going to be maybe answered by the Helion team. What do you attribute to the strong sales volume of paracetamol, Panadol Extra compared to Panadol Advance? Probably 2-in-1 in our shop. And why do you promote Panadol Advance more than Panadol Extra? Yeah, so maybe that's something you could address. So the first two is for you, Prof.
Yeah, thank you so much. The question on caffeine in Panadol Extra, whether it poses a risk for hypertension, I'm aware that before the formulation of those products, studies must have been done, and the dose may not be so high to those patients who are likely to be hypertensive, such that it can aggravate hypertension. However, it is always going to be on the safe side, where these patients come and they are maybe uncontrolled hypertension. Don't give something which is likely to exacerbate the hypertensive conditions. Then on the alcoholics who have, this is an interesting one. On the alcoholics who have perhaps rheumatoid arthritis, remember paracetamol and the liver toxicity. Again, should we use paracetamol? The answer is, if they don't have overt liver disease, then you can use paracetamol. But if they present with condition which whereby you are suspecting that perhaps it could be a sign of liver disease, then reduce the dose or maybe do not give paracetamol. Okay? For the inflammation, perhaps for the inflammation of those joints in arthritis, could be osteoarthritis or rheumatoid arthritis, then we would prefer giving the topical agents, particularly if we have fewer joints which are involved. These patients are required to be counseled and to be given the topical NSAIDs, the topical agents. And you need to do a lot of counseling with them and tell them the effects of the paracetamol and the liver toxicity when they combine with alcohol. Thank you so much. Dr. Ezra, over to you.
Right, thank you, Prof. Maybe we can have the response from Vivian, and then we can get back.
Yeah, so I'll actually go through some of the questions that I think maybe have also not been addressed here.
Okay.
There was a question like Optisob, does it disintegrate enzymes, or it's just the excipients which dissolve faster? So here, it's because of the crospovidone, which is actually the super disintegrant. So this is what actually leads to the quicker onset of action. You remember we talked about 3 components that Optisob technology has, and one of them was the crospovidone. So crospovidone is actually a super disintegrant. So that is what leads to the quicker onset of action. Then question number 2, does it mean that Panadol in use all these years before the Optisob technology was too slow to work? Actually, Optisob technology has been present with us for the last 10 years. So it's not something new that we are introducing now. We are actually emphasizing why Panadol is more distinct within the market setup. It's just that most of the times we tend to forget, and so we have to keep on reminding ourselves why over the years is still maintaining the first line the first line treatment when it comes to the analgesic use. And then the third question was, does caffeine content in Panadol Extra pose a risk to hypertensive patients? So here we have to use it with a lot of caution, because patients also react differently to drugs. There are those who will tend to get palpitation, but there are those who, when they consume, it will still be okay with them. So we advise that you use it very cautiously. And maybe we can just advise the patients not to consume it, a lot. Normally, when you look at the dosage requirement for any patient taking paracetamol, then we advise that Panadol should be taken 3 to 4 times in a day for at least 3 to 5 days. If the pain persists thereafter, then it means that either there is an underlying cause that has not been properly diagnosed. And that's why we also still encourage you that when a patient walks into the pharmacy and maybe they want a more stronger painkiller or combination, then kindly just talk to them, ask them and inquire how many times have they taken that Panadol, because some of them also fear drugs. So you find that instead of taking 1 gram, they will actually consume 500 grams, which is 500 milligrams, which is an underdose. Then you find that instead of them taking it either 8-hourly or 6-hourly, they took it like maybe the last 10 hours, and they still expect the effectiveness of the drug to be present. So these are some of the conversation that we should actually engage our patients thoroughly, just to find out why they would wish to go for a different drug. And then there's this question that what attribute to the strong sales volume compared for the Panadol Extra compared to the Panadol Advance, and why do we promote Panadol Advance more than the Extra? So again here, this one is based on pain severity, because nowadays when you look at the patients, they also tend to Google a lot, and maybe some of them just want something that is a bit much more stronger but less harmful to them. They want something that is not addictive. They want something that is going to give them that quick relief without really spending a lot or more time in the hospitals. Then apart from this, you also find that it is also used for mild to moderate pain. There are those patients who will just prefer taking it. For instance, you also find that there are also those patients, when they have like slight headache, they would prefer to take a cup of coffee before they decide to seek any therapeutic advice. So for such cases, you find that majority of the patients will tend to go for it as compared to the Panadol Advance. Then you also ask about why we promote Panadol Advance more than the Extra. It is because it is the basis. We start with what is most basic. And when you look at the Panadol Advance, it is actually meant for mild to moderate pain. So majority of the patients will tend to present with that higher percentage as opposed to more severe pain. Sometimes when they have severe pain, some will not even come to the pharmacy direct. They will prefer to go to the hospital. So that is why we are looking at the bigger percentage of the patients that will actually walk into the pharmacy. That is why we concentrate more on the Panadol Advance. Secondly, when you look at the pediatric formulation, we have the Panadol Infant, baby infant, which is meant for 1 month to 5 years. And then we have the Elixir, which is meant for 5 years to 12 years. And one of the things that we are looking at safety. I remember there was a question which was brought up, and it was asking on how safe paracetamol is. So that is one of the things we look at. And therefore, when you look at the pediatric combination, we actually have a syringe that is calibrated per weight to ensure the accuracy of the dosage. So for those patients or kids who are above 12 years, when they want now to transition to tablet, they have now the Panadol Advance. That is why we market Panadol Advance more than the Panadol Extra, because we have a bigger population who actually depend on the Panadol plain before they opt to go to other combinations. Thank you. Back to you, Hezron.
Right. Thank you. Thank you so much, Vivian, for that. So I think because of time, we'll just tackle a few more questions, just two, and then the remaining questions we'll be sending them over because we have the upcoming session that's going to be a continuation, and Prof. Nyamu will be giving a response to some of those. So maybe Prof. Nyamu, we can just close with two more. There's two from Dr. Kadare, who's asking, what's your opinion on the role of MTM in pain management by pharmacists at the community level? And also, what is the referral model within pharmacist level of specialization before moving to the medical clinician? Maybe you can address that, and then we can move on.
Wow, thank you, Dr. Kadare, for opening some very nice discussion. I know Dr. Kadare is very passionate on the MTM at community pharmacy level. I would actually encourage all the pharmacists to practice MTM. I know in the previous years we have not been taught, but it's something very easy that you can actually embark onto. The people who are practicing and do the MTM in pain management at the community pharmacy level. So it is encouraged. And I believe that if you do the MTM, you are likely to recommend the most appropriate analgesic. Then on the referral mechanisms between the pharmacists, well, among the pharmacists, the consultants, we know now we have various levels of specialization in pharmacy. We have the clinical pharmacists, we have pharmacovigilance, we have other people. So we would also encourage whereby you find a case is very complicated, like these patients who come with the multiple comorbidities, with hypertension, with the CKD, with the diabetes mellitus. If you can refer among yourselves before to the next high level person who is more experienced than you, who has more training than you, then it would make some sense before you refer this patient to the consultant. But remember, it is also expensive to refer them. And if it is something which can be handled at the community pharmacy level, the better for the patient. We are trying to save for this patient. So it would be encouraged. I don't know whether the pharmacists do that at the community pharmacy level, but personally, I would encourage that kind of a referral to somebody who has more training, like a clinical pharmacist who has more experience, who can actually assist. And you also be learning from that. Thank you to you. Thank you. Over to you, Dr. Ezra.
All right. Thank you so much, Prof. Nyamu. So I think we should be winding up now, and just like to welcome some parting shots. But for those who still have some burning questions, we'll be having another session on 14th of April. So some of the questions that are still pending are going to be responded to during that session. So I think at this point, I'd like to just welcome again Prof. Nyamu to give a parting shot, and then we'll have from the Helion team, Vivian giving the parting shot, and then we'll move into the announcements.
Thank you very much. This has been a very wonderful discussion. I've actually not discussed anything new to the participants. Having pain, it is the wearer of the shoe who knows how it hurts. and they recommend the most appropriate analgesic, balancing the clinical aspect and the monetary aspect. So please make sure you select the most appropriate analgesic. Balance your clinical aspect with the economic, the monetary aspect. Thank you very much. I hope to meet you on 14th when we discuss now more on the pain management at another level. Over to you, Dr. Hezron.
Thank you so much, Prof. Next we'll have Vivian.
I would also wish to take this opportunity to thank each one of us who was able to join this meeting until this particular point. It was very interactive. And the parting shot from Halion today is that Panadol Advance is not just paracetamol. There's a reason why we gave it the name Advanced, and it is because of the OTC technology. It is the same way Coca-Cola has its own secret that can never be imitated. So that is why we stand here today, still looking at partnering with all the HCPs here and giving the best medication to our patients, which is safe, which is efficacious, and which is also, we are also looking at the rational use of NSAIDs. Because when you look at the rational use of antibiotic, we are also not leaving behind stones which are not which are unturned. We are also looking at partnering with you so that we give rational use of analgesics to our patients. So even as we leave this meeting today, remember that Panadol Advance is not new. It has been existing for the last 70 years, and it is not just paracetamol. In short, it cannot be compared to any other standard paracetamol in the market. Thank you.
All right, thank you so much, Vivian, and even for the support. Really appreciate. And also, I know Caleb is also there. Really appreciate for the support that you've given for this webinar. Samson, Kikuvi, and also Enid, really appreciate the support that you've given to make this webinar happen, and we're looking forward to the next webinar series. And Prof, we really appreciate also for your time, being able to share the presentation with us today, and we definitely look forward to the upcoming session. And just before we close, I'll be doing a couple of announcements, and then we can close the meeting. So the first one is with regards to subscribing to the webinar. If you have not done so, ensure that you do so. You can use the keyword OTC so that you're able to find it easily. Remember, we have a 7-day window to be able to subscribe and claim the tokens. And for those who've had issues with the CPD, you can reach out to our national CPD coordinator via cpd@psk.or.ke. The other announcement is with regards to the conference that is coming up on 24th to 26th of June, and it will be happening at Pride in Paradise. Remember, we have different categories for the conference rates, and we've had the early bird since the start of February, and it's ending today, which is discounted. So if you've not signed up, ensure that you do so to take advantage of the discount. The other thing is on the call for abstracts, which is ending on 15th of April. So if you have any scientific submissions you'd like to do, ensure that you do so within the timeline that is provided. You can get more information on this on the site under the conference section. Next week, that's on 9th. I'm not sure if it's next week, but between 9th to 11th of April, we'll be having the Kenya Pharma Healthcare Expo, where PSK will be participating, and we'll be having a booth there. So if you have any questions that you'd like around some of the things that are happening at PSK, and just to connect with the leadership, ensure that you create some time to visit the expo that will be happening at Sarit. We also have a Pharmacist Prayer Day that is coming up, and that's going to be on 11th of April, which is on a Saturday from 9 a.m. to 11 a.m. Just be on the lookout for the communication on the location that's going to be happening. Then there's also the Med Expo, which PSK is also participating. That's between 22nd to 24th of April at the Sarit Expo Center. Ensure that you just book your calendars so that you're able to attend this. And finally, with regards to reporting of suspected adverse effects and poor quality health products, remember there are 3 options in which you can do so. First, it's through the PVAS system, where you can go to pv.pharmacyboardkenya.org. That's for healthcare professionals. Another option is through the mobile application, which you can download through the Google Play Store or the Apple Store. And finally, the USSD code, which can be used by the members of the public, *271#. And I think that's the last announcements. For those who've not followed us on our social media pages, these are our social media pages. Ensure that you follow so that you can always get the updates on all our upcoming activities. Once again, thank you all for attending this webinar. Really appreciate you for staying up this late. And for me, it's just to wish you all have a good night and a happy new month from tomorrow. Goodbye.
Bye-bye. Thank you so much.